Hello, assalamu alaikum, everyone. Hope I'm audible to everybody. Am I audible? Can somebody type on the chat box, please? So I welcome you all. Bismillahirrahmanirrahim. This is Dr. Saad Alam. I'm a graduate of Jinnah Medical and Dental College. After graduating, I did a few internships here and there. Then I completed my residency from Abbasi Shaheed Hospital, Karachi. Okay, so the topic for discussion that I chose today is quite crucial as it's a major exam as well as a major viva topic. And not all hospitals carry out these kind of surgeries, including my hospital, the government setup especially. So I'm sure that a lot of you in the group had also been facing the same problems. So there was always a lack in studying, and when we used to study the books, there was always a lack in not seeing the practical visuals of it. So that led us to a lack in the subject for that matter. So I learned it the hard way because fortunately I had an opportunity to work at different hospitals as an intern after my residency and even during my residency of um, when I got an off from the residency program. So thanks to the various professors that taught me and allowed me to their hospitals to be there and to watch their surgeries as an intern. Really grateful to them. Plus, thanks to the live Zoom sessions that were conducted by the AOCMF Foundation as well as the Royal College of Surgeons that have taught us, despite of the limited facilities that we had and that I stated previously, that we were not able to actually see these type of surgeries at every and each hospital in Karachi. And I'm sure many of you who are attending this session today are not from Karachi only. Most of you are from Peshawar as well as Hyderabad as well. I'm sure everybody must have been facing the same problem. So without further ado, let's start and begin with the session. There are a few rules to this session before starting. I would like to request you all to stay muted, number one. Number two, all the questions I will answer from the chat box, and I have made my friend co-host, who is Nida. Nida will try to answer your questions from the chat box. And in the meanwhile, I'll be focusing more on the Viva candidates. But there is, I'm sure in my presentation, there is uh, something for everybody to learn, inshallah. So just let's begin. This is the first slide of my session, which is the most important one in the entire presentation. I'm saying it because any error at this point will be very unforgiving later on in the treatment stages. So the point to note is I want you to imagine that you are that it is your first encounter with your orthognathic surgery patient in your OPD right now. So I'll be focusing on which points, what are the questions that you should ask from the patient? How will you take the patient and you see the patient in an OPD setup, and being a professional, how will you go on with this? I'll kindly request you all to please mute your mics. Okay, so going on with the session, I have a patient in the OPD. I would like to talk to that poor patient in a gentle, polite manner. I will like to introduce myself, and I'll want to ask the biodata of the patient. First and foremost, by doing all that simultaneously, I'm also getting a picture of my patient's psychological interpretation in my mind. The patient's compliance is also somewhat, I'm getting some information about the compliance, as well as whenever he or she is talking to me, and how nicely and how gently how gentle is my behavior towards them. So that is important whenever talking or whenever receiving an orthognathic patient like that. So first of all, when I get a patient in the OPD like that, I'm focusing on the inspection details. Before proceeding towards the history, as I stated previously, I'll get all the information regarding the patient, the biodata, the gender, the age, and everything. Simultaneously, my mind should be working 3D at this point. By 3D, I means I will be I have to focus this patient not on the basis of the cosmetic deformity only, but I would like to include all questions and all scenarios in my mind as I'm seeing this kind of patient. I'll be interested towards the functional problems that he or she might be facing. There are a few set of questions for the orthognathic surgery. I would like everybody to look on Google the set of questions that are asked from an orthognathic patient, so that you do not miss, and there is a proper protocol. But most of the surgeons, most of the professionals design these questions by themselves. It's not a specific set of questions. You can do it your own set, but the most important questions, I'll be explaining that these points at least you should be asking the patient from the history only. Number one, their age, the gender that I've stated previously, and then now you're coming to the presenting complaint of the patient. By the presenting complaint of the patient, there are 70 to 80% of patients in our country who will be reporting majorly due to their cosmesis problems as well. But they do not know about the functional problems that they might be facing, but they won't be able to tell you until and unless you ask them specifically about their problems. So the first question that you should ponder upon asking these individuals is, when did they notice the first problem? When did they encounter the problem that they were facing, number one? And what is the reason that after so many years or so many months or so many days, they're coming to your OPD right now to discuss their problems with you? So this is not giving you only one information, it's giving you multiple information just by this question. Number one, it is also telling you the compliance. It is also telling you if the patient is only interested to report your problem to the OPD, or his or her peers or fellows or parents, or the family is quite depressed about his or her facial, about how they look and their appearance. So this question is giving you simultaneous issues that you can think about. So this is the first point in the history. Simultaneously, you will ask about everything, like are they facing any problems in the speech? Are they facing any problems during mastication? What kind of food do they usually take? Do they usually prefer very soft food that is easily chewable, or they can have a normal diet just like you? Secondly, the questions may focus upon the breathing issues. Is that the patient of a simultaneous, more severe problem like obstructive sleep apnea or anything like that? If the patient, is your patient a mouth breather or not? And the second, which is quite an important question, is that are there any patients similar to that patient in their family? Can it be a syndromic condition? Can it be a hereditary condition? So we move along with that. So you see, those participants who have recently joined us, I wanted to briefly tell you that we are discussing about a patient of orthognathic surgery, and that it is your first counter of that patient in your OPD. And we're discussing the problems that we should be interested in asking, the questions that we should be interested in asking that person or the patient. And now we'll take it from there. We'll, after they're very, as I stated previously, because of the lack of time and shortage of time, and I have to complete so many topics in such a small and concise manner. So I would really request you all to kindly go through the set of questions that you should ask each and every patient of your orthognathic who is coming in your OPD. Proceeding with the examination. Now, whenever you see an examination, whenever you want to do examination of a certain individual, especially the case of orthognathic surgery, you would want to place your patient at a posture that, in a posture when they're Frankfurt horizontal plane. Everybody must be remembering the Frankfurt horizontal plane that we used to draw on the cephalometric radiographs. So the Frankfurt horizontal plane of that individual coming in your OPD should be parallel to the floor where he or she is sitting. So, how can we make that possible? Because since it's an imaginary line, you should even place a mirror in front of the patient, and you can ask the patient to look straight ahead so that the posture becomes upright and there are no drooping of the shoulders or anything like that. And that now you're quite sure that your patient is in the proper position. You can analyze the problem in a better way. So proceeding towards the examination, number one, what are the things that you are interested to look on inspection only? I'm sure you will be quite surprised to know that there are over 10, 20, or even 30 problems that you can only point out, and you can inspect just on the basis of their profile view and the lateral view. Just by inspecting the patient, you can immediately tell. And it's very important to proceed that in a very systematic manner so that you do not miss anything. So I would like to tell all of you that, like everybody, I was not the lucky one, and I did not pass my FCPS Part 2 theory exam in the first attempt. It took me 2 failed attempts to reach where I am now, and even 2 viva attempts. So that I stated previously that I learned it the hard way. So there are many things that I learned from my seniors and even my professors who trained me. So there are certain important points that you should focus upon. Number one, you should always think in an organized manner, and you do not want to miss anything especially in your clinical examination of an orthognathic surgery patient. What I do is I either go from up to down or from bottom up. By that I mean, as you can all see in picture A, let me yes, from picture A we can see. Is everybody able to see my annotations? We can go from top to bottom. Now I'm going from top to bottom here. So either we can divide the face into 3 halves, starting from the hairline to this glabella portion, and then glabella to this subnasal portion, which is the columella portion. And then you can proceed towards measuring the height between the columella to the base of the most prominent point in the chin. Now, it's not just about facial proportions. This is a very common thing, and you can find it everywhere in the books and anywhere, that the facial thirds should be symmetrical. That means this point from the hairline to glabella should be similar to the glabella to the columella, and then columella to the base of the chin, these points all should be symmetrical. That means there should be no height difference in any of the facial curves. This is one point. But what I was trying to say previously is that you're not only looking at the facial proportions, you would also like to see the facial profile in this case. For example, in picture B, you can all see that it is kind of a convex facial profile. So you would not like to miss these information, and you want to proceed in an organized manner. Okay, now coming from top to bottom, I would also like to see the hair of the individual. The hair is important for two reasons. It can also, the hair is important because there are some syndromes like the Perry-Romberg syndrome, in which the facial hair can be less on one side and on the affected side, I mean, and can be normal on the and completely normal on the contralateral side. So you should look at the hair proportion, then you should look at the symmetry of the eyebrows, symmetry of the pupil, symmetry of the ear, everything coming in one line. Sorry if that makes quite twisted since I'm doing it manually. So the ear lobes should be at a proper position as well. And then we're coming towards the ear, the helix of the ear, the lobule of the ear, the nasal symmetry. Is there a nasal deviation or not? And if it's a nasal deviation, each and everything you will simultaneously be mentioning on that examination findings of your paper. That would be very, very important in the entire treatment planning. And then where were we? Okay, we were looking at the pupil. Sometimes in syndromic patient, it happens that one pupil may be protruding. The one eyeball may be protruding out, and another eyeball may be going inside. Sometimes they may, in a facial asymmetry, you're already looking at a facial asymmetric patient. So that facial asymmetry can happen at any place of the patient's face. Like the asymmetry can happen anywhere. The pupil may be asymmetric. The whole globe may be asymmetric from the contralateral one. Then you come to the nose, you look at the nasolabial folds. Is there enough? Okay, simultaneously, you're also looking at the soft tissue profile of the patient. If any point it's making you difficult to understand, kindly write the question in your chat box, and I'm sure my co-host Nada would be answering and for helping you guys. Okay, so we're done with the eyes, we're done with the ears, now we're at the nose. Now we will like to see the nose. Is there a nasal deviation? That is the tip, is this the dorsum of the nose? If you draw a straight line, is the tip deviating to the right or to the left? Is there any alar flaring? Yeah, that means I'll tell you what it is in the next upcoming slides. Sometimes a patient do not complain, but sometimes we see the patient with alar-based flaring. And alar-based flaring is an important feature in some kind of problems that I'll be discussing in the next slides. Okay, now we're done with the nose now, then we look at the lip. Are the lips in repose? Are the lips at rest? Ideally, when you place a patient with the Frankfurt horizontal plane parallel to the floor, you should ask the patient to relax their lips. Again, that would help you in better analyzing the problem. Then you would like to see the gingival show, the incisal show. You should be all aware of how much is the normal gingival show in females and how much is the normal gingival show and the incisal show in males. In females, it's more as compared to the males. And it's quite representative of feminine beauty, maybe. So next, there is the gonial prominence. Okay, there's a term called the bigonial width, and there's a term called the bimaxillary width. So the bimaxillary width is a 25%, you can say, greater than the bigonial width. So all of these things you should mention. See, in this patient, there is a deviation towards the left side. Every deviation, even septal deviation, the nasal deviation, you should all write down in your paper. As well, now we're coming towards the neck as well. Do not miss out the neck. Sometimes there is a tracheal deviation in some patients. You should also comment on that. Is the trachea is in midline? as in this patient or not. Now we have also commented on the lips. Some information on the lips I missed out. Sorry. The information regarding the length of the lip should also be mentioned. The fullness of the lip should also be mentioned. Now looking at the in orthodontics, and whenever evaluating a case like that, and whenever the patient is seated on your dental chair, the most important view for a very good diagnostic analysis is for us or for the orthodontist is the lateral view, just like this patient. You have already, even the ceph tracings that we do is a lateral ceph, as we all know. So the lateral view of the patient in the lateral cephs gives you the most information regarding whether it's a skeletal, which kind of a skeletal deformities. Is it a class 2? Is it a class 3? So yes. So in this patient, you can see if I draw, and if I'm drawing the line, I'm talking about the picture D. I'm drawing the line that roughly encompasses the entire face, and it's making the face look a bit convex. So I can safely say that my patient is a convex profile patient and is not a concave profile patient. Now, what do we mean by the convex and the concave? It just simply means that if any individual, if the facial profile is convex and not concave like that. The concave means if the mandible is being a little protruded, if it's a class 3 skeletal relationship, the mandible will be protruded, giving a slightly concave appearance. In this patient, you can also see that there is no concavity, it's just convexity. So there is no mandibular prognathism for sure. There can be bimax hypoplasia, or there can be a skeletal maxillary hypoplasia, but the mandible seems normal. That we can only confirm on the ceph tracings and the model, because a good diagnosis is based upon not only the history and the physical examination, but of course the imaging and the pre-surgical. Okay, coming on the, okay, I think I've mentioned all the important points regarding the facial profiles and the facial analysis, how we are coming to the diagnosis. The next important thing is the imaging. We all know that we cannot work without ceph tracings. 70 to 80% of individuals, especially if you're working in Pakistan and if the hospital facility do not allow us for virtual surgical planning, a ceph tracing is a very good and a very mandatory investigation. But at the present times, it is quite mandatory to have CBCT or a 3D CT evaluation of the same patient as well. All of these imaging combined will still not give us the entire picture until we do not pour the models of our patients and we do not fabricate the models with the plaster of Paris, and then we will proceed further. So I spent quite a lot of time on my first slide. There are 29 more to go, so we're just be proceeding. Sorry for this annotations. I do not know how to delete them. Okay, history examination, inspect. That's this same continuation of the previous discussion. Think beyond asymmetry. The point that I was telling you, I was telling you guys previously, that think beyond asymmetry. It's not just what it seems. It is not just what it appears. You should go in depth of it. Like you should be asking about specific questions about in that case, you should be asking specific questions about the breathing as well, the obstructive sleep apnea. You should be asking questions about TMJ. If the patient, most of these patients, especially in class 2 patients, they have a tendency for TMJ disorder. So you have to really go in depth and find the details if the patient is already suffering from a TMJ disorder. He or she may straight say no to your query because they do not know what a TMJ disorder is. For that matter, If you're doing a proper clinical examination of your patient, you should not miss the joints. You should not miss the sensations even. You should not miss the cranial nerves even whenever you're looking at the asymmetries. Because these are very, very crucial, and missing such points can also lead to failing in the last in our exams as well. So think beyond asymmetry. The age of the patient is quite important. I will ponder and I will discuss the age factor in the upcoming slides, which is very, very important. And I'm inshallah, everybody will have something to learn from this session. The gender. There are some syndromes that are more common in males and some are females, and there are some clefts that are more common in males and some clefts are more common in females. So gender may be, and then the gen, and then coming to the type of the asymmetry, how severe is the asymmetry? Is it a functional deficit only? If it's is it a cosmetic defect only, or is it summed up with the facial defects? The amount, by amount means how much is the skeletal discrepancy, how much is the your maxillary deficiency or maxillary excess, how much is your mandibular deficiency or mandibular excess, is there any concurrent TMJ problem, is it the patient of your, is the patient of your is the patient also suffering from hemifacial microsomia, or is the patient a candidate of condylar hyperplasia or hypoplasia, and all that things. So only the history and only the clinical examination would take a hell lot of time if you're doing it correctly. If you're not, if you're taking it a very less time, that just simply means that you're not doing it in a proper manner. Okay, obstructive sleep apnea, we'll discuss in the further slides. Syndromic versus non-syndromic. You have already, by this time, you must be completely knowing about your patient thoroughly, and you have asked all these specific questions, and now you're seeing the intraoral examination. In intraoral examination, I will discuss one point in the next slide, but before that, we should look at the opening. How much is the opening? In this slide, you can see that the bite of the patient is shown here in the frontal view and the lateral view, and the arch can be seen, the palate can be seen. So the missing teeth should be outlined. If implants are done in any of the teeth, they should be outlined as well. So after the intraoral examination, the intraoral usually comprises of an overjet investigation, an overbite or overjet investigation. If the patient is in crossbite, how much is the crossbite? If it's an anterior open bite, if it's a posterior open bite, if it's a crossbite. These things will give you an idea about the transverse discrepancy of the patient. If your patient is having a deficient maxilla in the transverse plane, then he or she should complain of a crossbite. And then we go towards, okay, this is, as you all can see, envelope of discrepancy. Envelope of discrepancy is, it's just a fancy term, basically. The envelope of discrepancy is separate for orthognathics, and it's separate for us orthognathic surgery. So by orthodontic, envelope of discrepancy means that how much tooth movement can be done by an orthodontist safely to change the position of the teeth and to align the teeth. How much deficiency can be tackled, basically. And envelope of discrepancy for us is this that I have labeled in my slide. Okay, just learn it by heart. Maxilla, we can push up the maxilla 5 millimeters safely. We can pull down the maxilla 5 millimeters safely. Maxilla can go back, but it's not advisable, but it can go back up to 2 millimeters posteriorly, and 5 millimeter, it can be advanced. Okay, in the mandible, similarly, there is, the literature says that we should not consider advancing the maxilla more than 7 to 8 millimeters. And if a setback is required, we should not set back the mandible more than 7 millimeters again. And if more than 7 millimeter setback is required, then we should go for a bimax because to decrease the chance of a relapse. Okay, or you can co-combine it with genioplasty. And it's also stated in the literature that if we want to set back the maxilla more than 7 to 8 millimeter, we should opt for an osteotomy different to the normal sagittal osteotomy, that is an inverted L or intraoral vertical ramus osteotomy. Okay, coming to the next slide. Okay. So there are a lot of angles and there are a lot of analysis. I do not want to go in that much depth, but since everybody is here and most of you must have passed the FCPS theory or must be in the IMM phase of your examinations. So there is I would just like to I have included very specific and very important points in this presentation that you really do not want to miss. And I've only chosen those points that are helpful for the examination point of view. So this slide starts with know yourself first. You should be able to know what the special points in your ceph are, the nasion, the orbital. For starting with the Frankfurt horizontal, it's the horizontal, it's the plane in which the habitual postural position of the head is placed, the Frankfurt horizontal plane. The nasion is the most anterior part of the frontonasal suture. That is the N line, or you can label it as N, or you just call it as nasion. Point A is the most concave point on the anterior maxilla. Point B, most concave point on the mandibular symphysis. Orbital is the most inferior point on the margin of the orbit. Posterior nasal spine. This is important because from posterior nasal spine, you can evaluate the posterior airway space. So that is important. I'll be again discussing in our next slides. So anterior nasal spine and posterior nasal spine. These are again important for the airway evaluation. Okay. These points you should all know. I'll roughly jump through this slide. Here you can see in the top left corner of this slide that I have evaluated the posterior airway space. It is a very simple way to calculate the posterior airway space. We do this only in patients who are complaining of breathing problems and in which whom we are suspecting a disease like obstructive sleep apnea, or we have a history of snoring and all that. So look at the upper picture right here. So you can see at the bottom that it's labeled MPH. So MP is the mandibular plane. We calculate the mandibular plane by joining a line from the point B to the gonion at the back, and we place a perpendicular from this line right up to the hyoid bone. We calculate this distance, and this is the